collaborative invited speaker series, and today I'm really delighted to welcome Tony Iton. Tony is a Senior Vice President for Healthy Communities at the California Endowment. He's been in that role since 2009, and there he really oversees a very large initiative to advance policies and forge partnerships to create healthy communities throughout the state. So it's a major initiative. Prior to joining the endowment, he served as director of the county health. He was county health officer for the Alameda County Public Health Department, where he also oversaw a program of public health practice that was very much focused on addressing the social determinants of health at a time when this was not as fashionable as it is today. So a real pioneer. In addition, he's a clinician. He served as a primary care doctor and as a physician for the San Francisco Health Department. And on top of all that, he's also an attorney. So he's also served as he's been an HIV disability rights attorney at the Berkeley Community Law Center, and also been a physician advocate for the homeless in California in many different roles. And he's really been, I think, a real pioneer in thinking about how the social determinants of health and place-based approaches translate into the practice of public health and policies writ large. So we're delighted to have him join us today. So thank you.
Well, thanks for having me. I met Anna through a video. I knew her through Unnatural Causes before I actually knew her. And I told her this morning that I actually quote her fairly often. I quote something she said on Unnatural Causes that it's kind of funny how these relationships form through these virtual kind of connections. Anyhow, so it's a relatively small group, which is great, and you guys are all academics, which is for the most part right, unless there's any community members here or practitioners or whatever, or maybe you define yourself as some amalgam of all of those things. So please, let's have this interactive as possible. That's how I learn. I'll show you a bunch of slides that were created just from questions that people asked me. Some of them I considered somewhat cynical questions, but I like those too. So let me jump right into this. I like to start this off by talking about narrative. And this is a quote. I'm actually going to read it, because you may not be able to see the whole thing. I will say then that I am not, nor ever have been, in favor of bringing about in any way the social and political equality of the white and black races. That I am not, nor ever have been, in favor of making voters or jurors of Negroes, nor of qualifying them to hold office, nor to intermarry with white people. And I will say in addition to this that there is a physical difference between the white and black races, which I believe will forever forbid the two races living together on terms of social and political equality. And inasmuch as they cannot so live, while they do remain together, there must be the position of superior and inferior. And I, as much as any other man, am in favor of having the superior position assigned to the white race. Some of you know who said this, I'm sure. If you do, just raise your hand. Okay, now the people who raised their hands don't talk. The people who did not raise their hands, guess who said this? Yes?
I'm guessing it was Thomas Jefferson.
You're close, but no, it's not Thomas Jefferson. Other guesses? You're not that close, but you're close.
In time and geography, where am I off?
It was a white guy. He is revered in this country.
Was it? I hope it wasn't. Was it Abraham Lincoln?
It was Abraham Lincoln.
No.
This is the Lincoln-Douglas debates, 1858. All right, so who is not surprised by that? Okay, now keep in mind, everybody's going to have to raise their hands to one of these two questions. So who is not surprised by that? Okay, good. I'll come back to you in a second. Who is surprised by that? Now, the people who didn't raise their hands, what are you feeling? Are you just stultified? You have no words? All right, somebody who is surprised by this, tell me why you're surprised. Come on, you're academics, you talk for a living.
Well, we attached Lincoln to the emancipation and that major change in our society.
Yeah, there's a monument dedicated to the guy, right? Is this carved into marble, on the Washington Mall? So the stuff on the Washington Mall is all about, equality and liberty and freedom, and this is how he presented himself publicly and politically in debating Stephen Douglas in 1858, a race in which he lost. It was a race for the Senate.
Took him 3 years into the Civil War to decide he was going to make it a war for freedom of slavery.
Yes. So part of this is really trying to understand that we actually have to look at the facts. The other part of this is this notion that there's a narrative in this country. There are a number of narratives, competing narratives. But these narratives are important because they shape policy. And policy creates conditions. And conditions create risk. And risk drives disease. So if you're trying to manage disease, you have to understand what's putting people at risk of disease. When you understand that, you see conditions in which people are living. Those conditions are shaped by policy and practices, or as Anna said, famously in Unnatural Causes, oftentimes it's the absence of policy in the face of abject need. And that policy is created by narratives. It's shaped by narratives. So if you want to engage in this work, you cannot ignore narratives. You have to change or emphasize the narrative that is consistent with the policies that actually build equity. So there are a lot of narratives that this country is formed on. This is one of them. You see this narrative now in the Republican presidential primary. This is about others. This is about some people are valuable, some people are less valuable. Some people are deserving of the full benefits of society. Uh-oh. Others are less deserving of those full benefits. This computer is very finicky. Okay, so let's keep moving. So this is basically about place and why it matters, and it's about me. This is where I grew up. Anybody know where this is? Who doesn't know where I grew up?
Montreal.
Yes, who said that? Now, why did you say that?
I happen to know you were up.
So she ignored the rules.
We didn't hear, where was it?
It's in Montreal, Canada.
Montreal, okay.
Montreal, Canada. It's a beautiful city. Montreal stands for, it's actually Mount Royal. It's an old volcano that's in the middle of the St. Lawrence River. This is a view from that volcano looking down on McGill University, downtown Montreal in the background of the St. Lawrence River. Behind there's a very beautiful city. I grew up there in the 60s, 70s, and 80s. This is my brother and I in Montreal. Canada has a social contract with its population. It's got universal health care, universal dental care up until the age of 10, universal child care benefits, highly subsidized post-secondary education. I went to McGill University for free. I could have gone to McGill Medical School for free. Very deep investment in community level resources, parks, community centers, hockey rinks, played a lot of hockey growing up. It was a wonderful place to grow up. I was a black American child. I was actually born in Baltimore, Maryland, and Canada invested in me. And then I left Montreal in 1985 to go to Baltimore, Maryland. Ended up at Johns Hopkins Medical School because I was told it was the best medical school in the world. I don't know if that's true or not, but there's a motto at Hopkins, which is, we may not be the best, but there's nobody better. Very insular there. As soon as you get there, that's what they're telling you every day. And so I was delighted to be there. I thought, I'm going to learn about health. This is the citadel of health in the United States. So I was very excited to be there. And I got a tour around the hospital with one of the upperclassmen, and this is what I saw. This is immediately adjacent to Johns Hopkins Hospital and medical school. And I thought, what's it like for this kid? What's the social contract for this kid? This kid, for all intents and purposes, is me. What would my life have been like had I grown up in that environment? And that's basically the whole question for me. It's like, how does this environment, this kid did not create this, just like I didn't create the environment in Canada in which I grew up. What is this kid owed? What's the social contract with this kid? And I treated kids like this at Hopkins day in, day out. And for me, I couldn't not see this environment. In fact, I was being driven around by this guy, an upperclassman, and he saw my mouth kind of hanging open, and he said to me, what's wrong with you? And I said, when was there a war here? I had no concept for what this was. I'd never seen anything like this in Canada, ever. And since that time, I have gone back to Canada, every part of Canada, to ask people to take me to the worst part of town. Show me the inner city. And people are like, what's that? And then they take me to some place where there's parks and trees and people are playing hacky sack in the park. They're like, why is this the worst part of town? And they'll say things like, well, there's a lot of renters here. Really? So I was being driven around by this guy, and so I said, when was there a war here? And I'll never forget what he said to me. He looked at me like I was an idiot. And he said, what do you expect? It's the inner city. And I thought, I'm supposed to expect this? Is this part of what being an American is? You just sort of, this is normal. And we've got a name for it. We call it the inner city. This is natural. This is how things happen. Why should I expect any differently? This is what happens when cities evolve. So I've been trying to explain this to myself for 30 years. And that's my whole career. I could end this talk right now, actually. I've been trying to figure out what this is and its impact on the health of this kid and what we can do to undo some of this. Okay, so I go back to Hopkins a lot. Hopkins hasn't changed. This East Baltimore area has not changed at all. In fact, Hopkins has bought it up and just cleared all the people out. Okay, and we know what happened in Baltimore not too recently, not too long ago, after Freddie Gray was manhandled by essentially the state. And those of us who spent any time in Baltimore, or parts of Philadelphia, or parts of New York or DC, don't find this so exceptional that this place ignites periodically. If you spend any time in East Baltimore, I'm always wondering why it doesn't ignite more often. I'm shocked that it happens only once every 25 years or so. I mean, this is an incubating stress factor where periodically the lid blows off of it. And it's not unexpected. It's very predictable. We've created this. And it's not just Baltimore. I mean, Time Magazine asked the same question. It's not just Baltimore. Does anybody know where this is? You're not going to guess based on this. Does this help you? This is Scott County, Indiana. Why is Scott County, Indiana significant?
HIV epidemic, drugs.
All right, who said that? Okay, so say more about that. What happened in Scott County?
It had to do with the drugs that people were making use of to get high. And they changed the formulation of the drug, put a coating on it, made it harder to inject, so people started both injecting that drug and then also going to other drugs, including heroin.
Okay.
Sharing needles over the injection when they couldn't take the pills or snort them.
Okay, so the drug was Opana, which is it's a prescription narcotic drug that, you're exactly right, people were grinding up and injecting, first snorting and then injecting, and then sharing needles. Does anybody know anything about the demographics of Scott County, Indiana? You can read that, right? So what are you reading?
Very white.
It's almost all white. It's almost all poor. A very high level of unemployment, very low level of educational attainment. This is Baltimore with white people. Now the incidence and prevalence rate of HIV in Scott County, Indiana is higher than in sub-Saharan Africa. Now this is a massive outbreak, and this doesn't even count hepatitis C. I'm putting it to you that this is the other side of the coin of income inequality. This is the same thing that's happening in East Baltimore. It's the exact same thing. These people are voting for Trump, but it's the same phenomenon. And I'm actually going to show you some data on
It's the
that.
same in a lot of rural America.
It's the same in a lot of rural
When you
America.
know, having spent time in places like Kentucky and such, you go down to the hollers, it's not all that different.
Okay, I'm going to show you some data that supports that as well. Okay, so the thesis here is does your zip code matter more than your genetic code when it comes to your health? I mean, that's the basic question. You know, looking at places like East Baltimore, Scott County, Appalachia, which matters more, your genes or your environment? And based on my experience, I think we have answered this question. So I ended up after medical school going to California and San Francisco Bay Area. For those of you who don't know what that looks like, this is sort of zoomed up. That's San Francisco. I became the health director for Alameda County. I'm showing you this because I'm going to show you a couple maps in a second. It's shaped like a boot that's very intent on crushing San Francisco. We haven't successfully done it yet, but we're still working on it. And so the toe part of the boot here is sort of the older part of the county. Oakland and Berkeley is up here. And there's a freeway that's sort of leads to 1970s era suburbs that are bedroom communities for the Silicon Valley. And then there's another freeway up here that leads to sort of 1980s era communities. They're bedroom communities really for the entire Bay Area. And then back here you've got this strange combination of rural goat farms and nuclear bomb makers. There's Lawrence Livermore National Labs, Sandia National Labs. They literally make bombs. One of my first tasks as the health director out there was to explain why there was a high level of plutonium occurring in goat manure piles. So we literally had to do an epidemiologic investigation around plutonium with the federal government. So when you're the health officer, health director, you're the registrar of all deaths, which was the favorite part of my job. I love being sort of like, you know, the death guy. So, I mean, it's a weird thing, but you know, death certificates are like so valuable when it comes to information about health and life. And on a death certificate, you can figure out what somebody died of, what their age was, what their race, ethnicity was, and where they lived. And you can take those 4 pieces of data and you can actually do some very interesting analyses of the patterns of death in a community. So we put together a database of about 500,000 death certificates because I was just fanatical about death. And the first thing that we did is that we went back in time to look at life expectancy because I became the health director in 2003 and I didn't know what my job was. I had literally no clue. There was no manual for a health director. It was just, and a health department, for those of you who haven't worked in local government, or even state government for that matter, how many of you have worked in a local health department or a state health department? Okay, so you tell me if I'm wrong. They're not really departments. They're really like holding companies that hold a bunch of programs that may or may not be related, that may or may not even work together, even though they're doing the same thing with the same populations, that take their marching orders from some higher jurisdictional level, not necessarily from the director of the health department. So I had this huge health department in Alameda County. In California, the counties are like states. They run Medicaid programs, they run hospitals. So I had this huge program, and I wasn't sure that I was anybody's boss, quite frankly. They called me the director, but then they would actually look for their marching orders from state officials anyway. So I had to try to figure out how do I add value to this mix? I wasn't sure do you need me? And so I looked at Healthy People 2010, and the first goal of Healthy People 2010, any Healthy People mavens here? Anybody know what the first goal of Healthy People 2010 is? It's to increase life expectancy for all Americans. And the second goal is to eliminate health disparities for various groups of Americans. So, not knowing what my job was, I figured that was my job for Alameda County, was to increase life expectancy and to eliminate health disparities. Not to decrease, but to eliminate health disparities. So I said, okay, let me look at these death certificates and see how we're doing. I went to my room full of, Harvard and Berkeley trained epidemiologists, and I said, what's life expectancy in Alameda County? And they said,
You don't know.
I don't know. And I said, well, it's the #1 goal of Healthy People 2010. They're like, well, we got a whole bunch of death certificates. Why don't you go figure it out? So I said, okay, let's do that. And when you do that, when you calculate life expectancy, you need the census as the denominator. So The census only started talking about anybody other than white and black in 1990. So if you want to go back before 1990, you can only talk about white, black, and other. 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 That's what the census called it, other. So this graphic just shows white and black, because other is a meaningless label. And we found that in 1960, life expectancy difference between whites and blacks in Alameda County was about 2.3 years. We actually went back into the 50s, but the data, there was a big flood apparently in the recorder's office in the mid-1950s, so there's this gap of about 3 years of data, but the lines cross in the early 50s. Life expectancy for African Americans in the 1950s was lower, or higher, than that of whites. And then they crossed, and it was 2.3 years in 1960. We think we know why that is, too. We think that that's real. 20 years later, it had more than doubled to almost 5 years. And then 45 years later, it had almost quadrupled to approaching 8 years. Keep in mind, the #1 goal is to increase life expectancy for all. So you could argue it's going up for both populations. So yeah, check off #1 goal. #2 goal is to eliminate health disparities between different groups of people. This is growing, and growing on my watch. I mean, in theory, if there was any real accountability in public health, I should have been hauled in front of some political body to explain why this was happening. But nobody cared other than me. So I had to literally haul myself in front of the political body and say, you should be angry at me for this. And they're like, oh, it's not your problem, it's not your fault, don't worry about it. I was like, this is the problem in Alameda County. This is fundamentally, we have to understand why this is happening. This is happening during a period of widespread growth in the medical industrial complex. You're talking MRIs, CTs, minimally invasive surgery, all of these pharmaceutical wonder drugs, that were supposed to bring us salvation. And during this period of time, this gap is widening. Now, again, I had a bunch of epidemiologists around me, so they said, well, this is homicide or this is HIV/AIDS. So we actually subtracted out homicide, HIV/AIDS. We subtracted out a combination of homicide and AIDS, and we found that that contributed very little to this gap. This gap is chronic disease. This is heart disease, cancer, stroke, lower respiratory disease. These are things that we ostensibly know how to treat, manage, and prevent, ostensibly. But the gap is growing, and growing pretty dramatically on our watch. And so the fact that it was chronic disease was good, because it wasn't some weird Martian disease that, came from on high. This was ostensibly stuff that we knew how to manage. The fact that it was growing suggested to us that we were doing something very wrong. And our pharmaceutical wonder drugs and medical industrial complex wasn't really helping us so much as far as that second goal of healthy people. So the other thing you can do with death certificates is you can actually look down to small geographic levels. If you've got enough data in each cell, you can calculate life expectancy down to neighborhood, which is what we did. And this was, I'll tell you, because I'm sure there's epidemiologists in the room here, this was a war. I insisted on doing this because I'd been in Baltimore and I noticed that you could walk 3 blocks and the neighborhood would completely change. My epidemiologist wanted to get me fired over this. They said, you can't do that. You've got to show confidence intervals. It's wrong. I said, we actually have the entire universe of data. We have all these death certificates. So I don't know what my confidence intervals are giving me there. So we took this battle up to the National Center for Health Statistics. And I won. And 2 of my epidemiologists resigned over this. I mean, they're very sensitive people, these epidemiologists. So I won this, and people weren't doing this at the time, going down to small geographic areas. But I thought it's irrelevant to do it at the county level. You're just sort of blending all of these various differences into one gamish number that tells me nothing. I need to know down to the level where I can do something. So that's what we did. We took the boot. There are about 150 census tracts in Alameda County. There are about 10,000 people in each one. And we calculated, using multiple years of data, life expectancy down to the neighborhood level. And this ended up on the front page of the San Francisco Chronicle. Because now we could tell people, give me your address and I'll tell you how long you'll live. And we weren't kidding. I mean, I'd be wrong some of the time, but I'd be right much more often than I was wrong. And I shouldn't be able to predict that, but I can predict it because we actually allocate life chances by geography. We segregate people according to how valuable we think they are and what kind of resources we think they deserve. And so this is the toe part of the boot again. This is the flatlands of Oakland, and that's the flatlands of Berkeley and Oakland, and this is some of our unincorporated territories in the county, where we see relatively high rates of premature death. And so I used to show this map, and people would say to me, this is why I create slides. People would say to me, I don't want to live in Alameda County, seems like a very inequitable place. And I'd say, is that really what you took from this map? I mean, it's not just Alameda County. So we had to start doing it in other places. We went to Cuyahoga County, Cleveland, worked with the health department there to replicate the analysis. We went to Baltimore, of course, I had to go to Baltimore. And there are neighborhoods in Baltimore where life expectancy is in the mid to high 50s on average. Today, I had to do Los Angeles because it's so huge. Just ended up on the front page of the LA Times. Seattle, King County, New York City, there's Philadelphia. Philadelphia, by the way, inspired this work because the Philadelphia Health Department had produced a social gradient analysis early on in the late 1990s, and it was the only one we could find in the entire country, which led us to do this analysis. Minneapolis, St. Paul, Boston, everywhere we've looked, we found these life expectancy differences on the order of 20, some cases 25, and in one case 30 years difference in the same city. We've done the entire state of California down to very granular detail at the census tract level in Los Angeles. The other thing you can do with this analysis, which if you're a data nerd like me, at the census tract level you can get a life expectancy and a poverty rate from the census and just do a simple bivariate correlation with life expectancy on that axis and poverty moving from left to right and moving from relatively wealthy to relatively poor. Each of those blue dots is a neighborhood in Alameda County. And you see life gets correspondingly shorter. And in an ideal world, this would be a completely flat line, right? How poor your neighborhood is wouldn't predict how long you live. But we don't live in an ideal world. There's a cost to living in a poor neighborhood out here, and you can measure it in length, average length of life. We call it the death tax. And we did it for the entire San Francisco Bay Area, did it for the entire state of California. Now you can't put this kind of stuff on the front page of a newspaper because nobody knows what it says. So we had to translate this, yeah.
I think you started by saying you were happy for us to interrupt you as you went.
I'm delighted.
Can you go back to that previous slide?
Yes.
So there's roughly a line there, but there's a lot of variability around that line. So what are your thoughts about what's driving that for any poverty level?
Yeah, so in the longer version of this talk, I'd give you the sort of the quadrant analysis here. We had Virginia Commonwealth do an analysis of all the census tracts in California. And we were interested in studying these outliers. We wanted to understand what was happening in those communities, why, despite their relative poverty, they had relatively high life expectancy. Anybody want to guess what we found? I know Anna knows.
Vast inequality within them?
No. No.
Transient population? Wealthier people moving in, like in Washington, D.C.?
No, it's simpler than that.
Social cohesion?
This population does have high levels of social cohesion.
Young population?
They tend to be young, but this is age adjusted.
Oh, age adjusted.
Immigrants.
Immigrants.
The immigrant health paradox. The longest living people in Alameda County, and probably in California, but in Alameda County is low-income Latino immigrants. And immigrants across the board. Immigrants from Africa, immigrants from Europe, immigrants from Asia are healthier, live longer in the first generation than native-born Americans. And then as they acculturate, their health gets worse. And we actually did a whole segment on the natural causes on that, the immigrant health paradox. So high levels of immigrants in these high poverty, high life expectancy communities. There are some other factors that we looked at, but nothing as powerful as the immigrant concentration. So to get this into the newspaper, you have to translate it. So we translated it into essentially the cost of life. And so we told people that $12,500 in household income buys you a year of life in the San Francisco Bay Area. And encourage people to use that when they're negotiating their raises. Now, some of you, probably were getting a little uneasy that I was showing you correlations and associations, and your blood pressure is rising because you know that doesn't prove cause and effect. And we don't really have a lot of ability to actually show cause and effect, but we have probably the best possible design that you could ask for in Alameda County, a longitudinal cohort study, 7,000 Alameda County residents from 1965, still ongoing. It's produced a couple hundred papers at least. Amongst those papers, those residents with a household income 1 standard deviation above the mean were 25% less likely to die prematurely. If you're 1 standard deviation below the mean, you're 35% more likely to die prematurely, which is almost an exact fit with our regression line. So we're actually quite confident that this data is meaningful and real. I mean, we obviously can't do a randomized, placebo-controlled, double-blind, experimental trial. I wouldn't want to live in a country that did that. Hopefully, some of you have seen this recently. Anybody want to say what we're looking at here? It was in the New York Times last week.
Fried chicken.
Yeah. So, anybody want to describe what he found and showed?
I think he used tax.
He used
data?
50 million tax records.
Tax records.
How he got 50 million tax records is an interesting question, but
He's an economist.
he's an economist.
Yeah.
And so what he showed is that it basically, when you stratify the population across the income spectrum and then across various different communities, once you're kind of wealthy or even sort of in the middle of the spectrum, your life expectancy kind of overlaps, but it matters where you're poor. It matters. Those environments actually have, presumably the environments, it may be the people, it may be immigrants. I'm talking to him on Friday, I'll try to figure out what he thinks. I don't know if he knows. But different communities have different life expectancies for poor people. And we think that that's some combination of what those communities do, how equitably distributed some of those critical human resources are. We also think it has something to do with the makeup of those communities. We think immigrants just tend to be healthier. But this is a very interesting question. Yeah?
Had you considered looking to see whether that is predictable from the overall income level of the city? Like to give an idea what, Detroit, we know, is extremely poor as a city. They don't have resources. And that's why I'm not surprised that they're the worst off in the bunch. If you correlated that might be the underlying factor.
In other words, the general poverty of the city actually would make it harder for the poorest of poor.
Because there's no resources available.
I'll ask Raj Shetty that on Friday. So I'm going to see what you've all seen this data. This is the data about per capita expenditures for health. This is nothing new here. If you haven't seen this, you don't belong in the school of public health or politics. You know, with this graphic, you always have to change the axis to fit the U.S. on the same scale as everybody else. And we know that for our spending, we should be up here. In fact, we're down there. That's not surprising. But of course, what is surprising is the work that Elizabeth Bradley and Lauren Taylor did. You guys know this work? I'm seeing a few. I'll explain. So this blue data is the same data I just showed you, which is U.S. healthcare expenditures per capita. What they did, and it's kind of funny, I know Lauren, she explained to me what happened. They sort of were just playing with a lot of data, and they got this data on European OECD country expenditures on social benefits. They call it social services in their book. It's really social benefits, like those benefits I described to you that Canada has in its social contract. And they found that when you add the health spending and the social benefit spending, that the U.S. is not the big spender. In fact, we're like kind of smack dab in the middle of the pack. What they found, which was much more interesting, was that those countries that spend disproportionately more on social benefits as opposed to health care had better health. So literally, we have the accent on the wrong syllable. We're spending it all here, downstream in health, and relatively little here which was presumably on prevention, and its prevention manifests as social benefits. And so, they originally published this as an op-ed in the New York Times. And it got so much attention that they actually wrote a book around that op-ed. And a book, it's called The American Healthcare Paradox, which is actually an interesting book because I think it would have been better as an op-ed in the New York Times, because they keep saying the same thing over and over again. And they talk about social services rather than social benefits. I don't think that the difference is social services. I think that's the American understanding what social benefits are. It's services wait for people to become eligible or to have some sort of crisis. Social benefits are an investment in people to prevent them from going over the cliff. Okay, so that's what they basically found, that the ratio of social to health spending was significantly associated with better health outcomes. This is a big finding. I mean, and surprising that all the health services researchers that have been looking at the same data over the years, that nobody saw this earlier. I'm actually kind of amazed that we hadn't seen this earlier. This is the spirit level. This is a little bit older data, and some of it may have been supplanted by Raj Chetty's data, at least the national stuff. So they looked at OECD countries, per capita spending, and once you kind of get that sort of, that epidemiologic transition where, your per capita spending is no longer about preventing communicable disease, you're now into sort of like the chronic disease. It looks like there's not much of a relationship between your wealth and your life expectancy, but if you reorganize these according to income inequality, all of a sudden you see a relationship. This is for OECD countries. So it's not how much money you have per capita, it's how those resources are distributed within those communities. Again, it's an association, it sort of suggests, it hints at maybe there's a meaningful relationship between these two things, but it explains better than just per capita income. And similarly, if you do this for the 50 US states, which they did in the spirit level, they use a slightly different measure here. They use an index of health and social problems. This was a while back. I'd love to see this data replicated now. Maybe Raj Chetty could do it. Looking at life expectancy, per capita spending, and then looking at income inequality and trying to see if that relationship still holds. In his data set, he said that the Gini coefficient, which is a measure of income inequality, didn't correlate with life expectancy at his geographic units, which were these things called commuter zones. I would like to understand that data a little bit better. Okay, then this data, which is interesting, which I'll just mention very quickly, it's sort of similar to the Lauren Taylor and Elizabeth Bradley data. This shows essentially, the blue line is basically what capitalism looks like in terms of how much poverty capitalism generates in a country. And so you see here in Ireland, for instance, just raw capitalism generates about 41% of the population falls under the poverty line before income and tax transfers, before social policy kicks in to try to blunt the impacts of capitalism. In the US, about 28% of the population falls under the poverty line before income and tax transfers in a variety of different social programs, and it only corrects it down to about 17%. Other countries do a much better job through social policy correcting down their poverty level. So we care less about trying to mitigate the impacts of naked capitalism. That's basically what that tells us. Now, I used to do this talk a lot where people would come up to me afterwards and kind of like whisper into my ear, there's something you don't understand because you're Canadian and you don't understand America, which is true. They would say that, America is this grand, welcoming country that takes in all these immigrants from all over the world, and, they're tired and huddled masses, brings them in, offers some resources and opportunities, and over time, they thrive. And therefore, what you're measuring in this data is essentially the poor, huddled masses, in their early phase of, becoming American. And if you took out all those black and brown people, of course they don't talk about African Americans and slavery and all that kind of stuff, but you took out all of those people, just looked at white Americans, we'd have really great health statistics. And so this was a number of years ago. So I said, all right, let's look at that. Let's look at the health of white Americans. So US whites live about 79 years, males and females combined, which is pretty good. It's about the same as Qatar and Costa Rica and Nauru. So, I mean, yay! But it's shorter than Belgium, Chile, Denmark, Lebanon, Slovenia, Austria, Finland, Germany, Greece, Ireland, Malta, Netherlands, Portugal, the UK, Canada, Cyprus, France, Iceland, Israel, South Korea, Luxembourg, Monaco, New Zealand, Norway, Sweden, Andorra, Australia, Italy, San Marino, Singapore, Spain,
Yeah, but
Switzerland.
we're good at Qatar, come on.
Exactly. And Japan. So that's 33 countries in the world have better life expectancies than white Americans. In 1990, that was 17 countries. US white life expectancy is plummeting in the international comparisons, plummeting. So we actually, when we talk about disparities, we should not be using white health as a benchmark. It is not good. We should actually be using immigrant Latinos as a life expectancy benchmark. I could do the same thing with infant mortality, by the way. I don't have to anymore because Steve Wolf at VCU through the IOM did this report called Shorter Lives, Poorer Health. So when you call a report Shorter Lives, Poorer Health, you know that's not going to be good news. That's like, it's not going to be good. And so this is the IOM, and I know Anna's on a couple of IOM committees. I've been on two. I'll never do it again. They
I
take
was
up.
on this one, actually.
You were on this one?
I was, yeah.
Okay, great. I was in Baltimore doing this, and Steve was there. And so I pivoted to him, and I said, so tell me about that title. And he said
Lots
that.
of debate.
Yes. So I like translating this for people who don't know the IOM, but maybe you guys know the IOM. But my translation of this first line, the panel was struck by the gravity of its findings, is holy shizzle, this is bad. I mean, this is the IOM screaming with anxiety.
Yes.
The panel was struck by the gravity of its findings. For many years, Americans have been dying at younger ages than people in almost all other high-income countries. This disadvantage has been getting worse for 3 decades, especially among women. The US health disadvantage cannot be fully explained by health disparities that exist among people who are uninsured or poor. As important as these issues are, several studies are now suggesting that advantaged Americans, even those who are white, insured, college-educated, or upper income, are in worse health than similar individuals in other countries. This got actually relatively little press. It got some press, but I think because it kind of contradicted the narrative, people literally just couldn't see it. They just, no, that can't be right. That's got to be wrong. That can't be right. I don't see that. We've been talking about this for a while. This is Health Affairs in 2012, talking about life expectancy for white, poorly educated females, showing that actually their life expectancy is now less than that of similarly educated black females. And particularly over the past decade or so, there's been this kind of precipitous decline in life expectancy in this population. The blue line is 1990, the green is 2000, and the red is 2008. And of course, you guys have seen, this was the op-ed that went along with that in the Health Affairs. Of course, you guys have seen Angus Deaton's. So I have a question that you can think about and answer later. Why is it that when economists say the same thing that public health people have been saying, it's on the front page of the bloody New York Times? What is that? This guy got a Nobel Prize! I mean, like, we have a movie about this. So, anybody can explain that to me. Maybe I trained in the wrong field. So this is some of Deaton's data, looking at sort of, African American mortality rates are still much higher.
Much higher.
But this is from 1999 to 2013. There's been a pretty good decline in African American mortality rates. Pretty decent decline in Latino, but a slight increase in white mortality rates. And then when you stratify whites by educational attainment, it's pretty flat for some college. It's still declining for college or more, but for no college, there's been a steep climb, and particularly amongst women. we have to understand that. This, I think, is part of that same phenomenon that we're seeing in Scott County, where people don't see a future for themselves. And when you don't see a future for yourself, you don't protect yourself for that future. You deal in the moment. And typically, you're dealing with trying to blunt the stressors that you're contending with in that moment. And drugs, cigarettes, alcohol, a lot of those things are actually pretty useful tools for blunting stress in the short term. I included this because I think it's really funny. It's probably not funny, but I think it's funny. And this is looking at the Republican primaries and looking at the correlation between white working class mortality and Trump voters, and showing a positive correlation. I think it's funny, and it's not really funny. It's the challenges that people are facing are real. These are real issues. It's funny to me because we're just now recognizing this. Because it's white people in places where Republicans are trying to get votes. And they're astounded by this Trump phenomenon. But if you ask public health people, we probably could have predicted this for folks. We probably could have predicted this. We should have. Nobody would have listened to us, though. It wouldn't have been in the front page of the Bloody New York Times. So at the California Endowment, my job, believe it or not, somebody gave me $1 billion in a decade to try to solve these kind of entrenched health problems in 14 low-income communities in California that are riddled with health disparities. They said, here's $1 billion, 10 years, go make measurable improvements in the health status of these populations over that decade. And I was like, great, I'll do that. And they said, wait, one caveat. You can't spend a nickel on health care. So this is a true experiment in the social determinants of health, investing in the social determinants of health. And that's what we're doing at the California Endowment, and it's damn fun. Let me tell you, it's like public health on steroids. Maybe not steroids, something healthier.
Heroin.
So, yeah, heroin. The healthy version. So we've been trying to tell people, first we're trying to share the data, because in this case the data is actually very relatable. It's basically like, tell me where you live, and I'll tell you how long you will live, based on the conditions that are operating in your community right now. That gets people's attention. We also tell them, the likelihood of high school graduation based on, these are real zip codes, real graduation rates, real zip codes, real life expectancies. Sacramento, which is our capital, built a new airport terminal recently where all the legislators fly through. We decided to have a conversation with them with this billboard. We know that they saw it because they started calling me, asking me why I was decreasing property values in their districts, which was important. APHA a few years ago, we literally festooned downtown San Francisco with these images that sparked this conversation. This is the governor's office in California who let us put this up for 4 months outside of his office for reasons I still don't understand. But it certainly sparked a lot of conversation. I mean, this is where all the lobbyists walk back and forth into the office to try to cut their deals. So we know this is, a school of public health, so you know this, 80% of what impacts your health doesn't happen in the doctor's office. Some people would say 90%. I might be one of them. 1993, the seminal paper by McGinnis and Fahey, which was radical at the time, they said stop talking about diseases. Diseases are irrelevant. There's only 4 causes of death, and we need to understand how to actually manage those. And that was radical thinking at the time. They talked about the environment, sort of defined fairly narrowly as sort of like the physical environment. Healthcare, which they gave only 10%. Biology or genes, which they said 20%. And then this huge category of so-called lifestyle, the things that people do to themselves. And this is still kind of the model. I don't know about this school, but I went to Berkeley. This is still kind of the model that's used in public health education. That these are the kind of the 4 pathways for understanding disease, and you've got to kind of choose a career in one of these things. Since that time, this is 1993, we've learned a lot. We know that this barrier between environment and genes has been broken down. We now have epigenetics, which I won't spend a lot of time talking about because I'm assuming you guys are fairly familiar with, but it's basically take two identical twins, put them in radically different environments, and their genes express themselves differently. So, this notion of nature versus nurture is now defunct. Nature interacts with nurture, which interacts with nature. Which gives environment actually much more power in trying to understand how disease is manifest. But that's not the most interesting part of this. The most interesting part of this to me is, how does the environment shape people's behaviors? And this is the one that used to piss me off in medical school. When we talk about socioeconomic status as a variable, and then we control for it. It's like, it didn't matter. It's like, all you need to know that it's in there somewhere. But there's nothing you can do about it. Or we talk about race, and we age adjust and race adjust, as if race was the determining factor, when it's racism that's driving these differences, not race. And I don't know, the cognitive dissonance in academia, and I'm not talking per se about you guys, certainly not this school, but I came up through an academic pathway which could say very easily, without even batting an eyelash, that these racial differences are basically genetic differences. And, therefore we can not do anything about them. And no mention at all of the isms. None. So I sometimes wonder if our biggest problem is the lack of critical thinking skills. I literally wonder, I was like, oof, can we think well enough to actually figure this out, or are we just stuck? So this is the big question for us, is can you change these behaviors, which are all powerful, but this assumption that they are occurring in a vacuum, where people have a wide variety of choices and options, and they're just sort of choosing bad ones because they're ill-informed. And is there anything that can explain why people in certain places seem to make choices that injure their own health interests? And I don't think we know the answer fully to that question, but we're starting to explore some recent pathways that would explain this. And allostasis, allostatic load, chronic stress is one of them, which for me was a godsend, because I used to spend a lot of time doing basically this presentation to places that had a lot of doctors. And doctors just sit there like, come on, this has nothing to do with me. I don't see anything here that has anything to do with me. Until we got to allostatic load. Because that explains how the environment gets under the skin and changes your physiology. And once it's changing physiology, the doctor's like, ooh, that's interesting. How's that happening? So when this came along, it actually made it increased the value of my conversations with my medical colleagues. I'll just say that one. So basically this notion that we have all these stressors in our life, and as David Williams says, another one of our TV buddies, the person who doesn't experience stress is dead. So we all have stress, we all have stressors. The only question is, what kind of resources do you have to balance those stressors? And most of those resources are not individual resources, they're policy-mediated resources. They're allocated according to political mechanisms. Nobody wants to challenge that? Wow. Okay, so basic physiological pathway, the stressor is interpreted by the brain through the hypothalamus, which sends a signal to the pituitary gland, which sends a signal to the adrenal glands, which releases a cascade of hormones, amongst which is cortisol in the acute phase. Cortisol stimulates cardiac output, it rallies available glucose for your muscles if you've got to flee or fight. It enhances your immune functions, it turns down your inflammatory functions. It's a steroid, so it's like anti-inflammatory. And it stimulates the growth of neurons in the hippocampus and prefrontal cortex, which are critical for what's called executive function. Anybody know what executive function is? Decision making. It's a form of thinking. It allows you to essentially choose from a wide range of options to match the circumstances that you're facing, short-term, intermediate-term, and long-term options, to make kind of rational choices based on your immediate conditions. And so you need all that in the acute stressed phase. When you're chronically stressed out, cortisol has almost the exact opposite effect on you. It stimulates hypertension and cardiovascular disease. independent of your behaviors. Independent of your behaviors. So when you're handing out that brochure which says, you know, eat right, you know, exercise, and you're like, I'm done, I've done it for this patient, you've done nothing. Because that stress chronically is actually ignoring your brochure, going under the skin and stimulating hypertension and cardiovascular disease in your patient. It stimulates glucose intolerance and insulin resistance. It actually causes inflammation, turns down your immune functions, actually stimulates infection, and then it causes atrophy and cell death in that same part of the brain that's responsible for executive function. Which, I'll tell you, I did this talk in front of the Department of Justice, this program called the COPS program, which is community-oriented policing. And afterwards, all these burly cops came up to me, you know, with their like guns and stuff. And they're like, I've seen this. I've seen this in people in communities that are chronically stressed. They don't make decisions the way you would expect them to make decisions. And I started saying that poor people and rich people are physiologically different in this country. Not because they were born that way, but because our policies have made them that way. Our policies have changed the physiology of low-income people to their detriment. I'm going to skip the telomere stuff because that's kind of a little too sciencey and I'm not sure how much time we have. So this whole notion of when you see disparities, you're only seeing the tip of the iceberg and you haven't really looked under the surface. God, I hope this works. There's a video I want to show you. It's only 3 minutes long. Are you going to work? Probably not. So, can I minimize this? And just pull up the video. This is a video that we made with George Takei, who's Mr. Sulu from Star Trek, to try to explain to people all of this, what I just talked to you about, in 4 minutes online. And you tell me what you think of it once it comes up. Don't apologize. I should be apologizing. Here, just minimize everything and maybe it's in the taskbar.
It's here, the video's here, it's just.
Well, in the meantime, let me take a couple questions while we're trying to figure this out. Yeah.
As a physician, I agree with you that what we do as doctors probably makes a lot less difference than some of the other things that you've spoken about. But I am wondering if anybody is trying to look at the effects of ACA and access to health care for 19 million more people than existed a year or two ago, if that is going to have any change.
Yeah. So I'll give you the short answer, play the video, and then we can have a longer conversation. The 5 million of those 19 million are in California. We claim, some contribution to that number. We're actually doing a longitudinal study now, looking at access, how access has impacted the health of that population.
A year's probably not long enough to see a lot of change.
This is a 5 years study. Okay, let's see if this works.
What determines how long we'll live? Is it what we do? Is it who we are? Actually, when it comes to predicting how long you'll live, your zip code is more important than your genetic code. Here's how this works. Meet Deb and Maria. They both have jobs, they're around the same age, they're both married, and they both have 2 kids. Deb lives in A-Town, while Maria lives in B-Ville, less than 1 mile away. They're similar in so many ways, but here's the thing. On average, residents of B-Ville will die more than 15 years sooner than the residents of A-Town. Why? Because where you live is about more than just your address. It's about your opportunities. For example, Deb and Maria's access to healthy options is really different. In A-Town, Deb's family is surrounded by healthy food options, including farmers markets, specialty shops, and grocery stores. The air in A-Town is cleaner and fresher. and there are lots of safe, clean parks where Deb can exercise and her children can play. A-Town has good public schools for Deb's kids and easy access to emergency and preventive health care. On the other hand, Beeville has broken, badly lit sidewalks, and the parks are unsafe. The air is filled with truck exhausts from the nearby highway. And for food options, Maria's only choices are Beeville's many liquor stores, fast food places, or convenience stores. The schools in Beeville are overcrowded and undersupported. And even if Maria can get her kids into better schools far away, she needs to figure out how to get them there without access to a car. So for Maria, having to juggle so much to find healthy options can be an overwhelming source of chronic stress, which is a serious health risk factor. In fact, for all the residents of Beeville, chronic stress drives health problems like obesity, diabetes, asthma, and heart disease. How did A-Town and Beeville get so different? Well, in many cases in cities and towns across California, the root cause was racial and economic discrimination. Over the generations, poor white people and people of color were pushed to less desirable parts of town. Where banks refused to lend money, businesses left, jobs too, schools declined, and the neighborhood crumbled. Everyone who could move away did. And what's more, when communities like A-Town and Beeville are so unequal, Beeville isn't the only one that suffers. Because it turns out that not only is your zip code a predictor of how long you'll live, so is what country you live in. Countries with the greatest income inequality have the lowest life expectancy. So even Americans like Deb, who are white, insured, college-educated, and upper income, die younger than their peers in other countries. In fact, our life expectancy is 43rd in the world, and that number is slipping. In the end, our biggest health risk may actually be inequality, and extreme inequality hurts us all. So what do? Well, if we're all going to be healthier, we don't just need to help the folks in Beeville beat the odds. We need to change the odds for everyone. And that's what we're doing. There's a movement happening. We're Californians. We don't follow. We lead. We are building the power to make health happen in communities across the state. We are coming together to build one California, a smarter, more inclusive and equitable state that creates health and opportunity for all of us. Join us. To learn more, visit buildinghealthycommunities.org.
Okay, so that's building healthy communities. And like I said, it's basically, the California Endowment used to be Blue Cross of California. Blue Cross wanted to become private. As part of that process, they have to go through this process called disgorgement. Believe it or not, they have to disgorge their assets. This happened in the mid-1990s. A number of us who were consumer activists, lawyers, we sued Blue Cross and the state of California. Blue Cross wanted to create a $100 million foundation. We got them to create a $3.5 billion foundation. And those assets are dedicated to improving the health of the people of California. So we're this huge bank account that spends about $150 million a year on just trying to improve health. Now that sounds like a lot of money. It's not a lot of money. California's an enormous state, 40 million people, geographically huge. And so our focus is really on trying to improve the environments on which people live, because we believe our theory of change is that if you want to get to health status, you have to look at the environments that shape people's opportunities, and you have to fix those environments. And we believe that those environments are created by policy, or the absence of policy in the face of need, and that if you want to change policy, you actually have to build power, social, political, and economic power, and a critical mass of people that are living in those communities so that they can effectively participate in decision-making that leads to policy that create the conditions. So that's the whole theory. We're blowing $1 billion on that. We're 5 years through. We've already spent $600 million. We have some results. are one of the big focuses, despite the fact that we're not spending on health care. We are spending money on improving people's access to health care. So when the Affordable Care Act came along, it was a huge opportunity to get people enrolled, particularly in Medi-Cal. The state didn't invest a nickel in increasing outreach in Medi-Cal because they didn't want to. We spent $350 million. And as a product of that, in part, we have 5 million new people in Medi-Cal in California. Now, I say that with mixed feelings. I come from a country where everybody's in the same system. I don't think that Medicaid, which is Medi-Cal, is an equitable system. I think it's better than being uninsured. But the fact that Medicaid pays different rates for the same disease than does Medicare still boggles my mind. I don't, other than saying overtly, you're less valuable than this other person with the same disease, I don't know what kind of message that is. It's just stratifying people according to their perceived value, which is the American way of doing business. Every other country has universal policies. In this country, you get this one if you're eligible for that, you get that one if you're eligible for that, you get nothing if you're eligible for nothing. Anyhow, we have 5 million more people in Medi-Cal, which we think is really important. We also have convinced the state to cover undocumented children, and we're continuing to push to get undocumented parents and adults in the full population covered through the exchange. We're actually asking the federal government to do that now. And a number of things in the criminal justice arena, a number of things in what we consider to be probably the most important institutional lever for health equity, which is schools, particularly for boys and men of color. California used to suspend and expel about 800,000 kids in a year, or at least they'd have 800,000 expulsions and suspensions. We managed to mobilize community to drive policy change. We got 7 bills to the legislature, dropped suspensions and expulsions down 40% across California over 3 years. In some of our sites, they're down to 0. And there's a whole host of environmental changes. I'm cutting to the end because I don't think I have enough time to give you all the slides. A whole host of environmental changes that pretty much look at land use, the whole land use enterprise, and try to inject health policy into land use decision making. So all of our sites are pursuing health elements in their general plans, or health policy language that informs the entire general plan. I'll conclude with this by saying that health equity is not only about the outcome. It's much more about the process. It's about the fight. It's about building the muscle of communities to essentially take on challenges and hold systems accountable. We want the nice parks and the water fountains and the sidewalks and the trees and all that kind of stuff, but we think if we don't go through a radical optimization of our democracy in these sites, none of those wins are sustainable. So equity is about the fight, and that's what makes it hard, I think, for foundations, schools of public health, healthcare institutions to actually do equity. Because to do equity is to give up control and to make yourself somewhat vulnerable. But at the end of the day, to my mind, health is political. And you have to build that muscle of people to participate in that political process if you want to see sustainable change. So I'll stop there. I think time-wise I should. And happy to take any questions.
I wish we had a California endowment here to fund us, but in the absence of California endowments around the country, I think we still, even though we have these conversations, it's still hard to get funding if you're not focused on a particular disease area and to build community to be able to address its own issues. Do you have any suggestions for us for how to change that or to fund such efforts?
Yeah, so a couple of things. One, there are, I don't think foundations are the solution to this, by the way. They don't have enough money. Government has all the money, and the private sector has quite a bit of money too. That said, Robert Wood Johnson is now engaging in their culture of health, which is sort of more of a place-based kind of approach, working with the local Federal Reserve banks. That's one potential source. But I think more importantly, you know, the drivers right now in the healthcare delivery system, Anna and I were talking about this morning, are really to get the healthcare, the $3 trillion that we spend in the healthcare delivery system, to essentially have more accountability for prevention. It's not very upstream. It's sort of just like outside the front door that, you know, they look around and they say, you know, who can I manage with services? I think that the future does speak to some potential for getting those healthcare delivery systems much more accountable for population level health measures. And the goal is to essentially change their incentive structures so that they care about the obesity rate in the community or the diabetes. Their bottom line cares about it. So I think that may be somewhat a ways off, but there's more talk about that. But in the short run, public health agencies have been talking about chronic disease prevention for the longest while. And I know there's no way to do chronic disease prevention but through an equity model. There's no effective way to do it. Because the things that shape the disparities in chronic disease are political. And so you have to enlist the participation of the very people who are most impacted by the inequity to solve those problems. You can't do it for them. And so the route to chronic disease improvement is through equity. And so what I've always encouraged my partners to do is whenever somebody says that they're interested in chronic disease, you've got to explore their model and try to shape their model to the extent possible into an equity model, which is really about a participatory model and a model that sort of looks at how policy creates those conditions that people, you know, have to navigate in order to avoid chronic disease. So I think that there's hope there. You don't have to call it health equity. You don't have to call it health disparities. You can call it chronic disease. That's a disease for some of the funders. They're like, okay, you've got disease, so check. So you can take that disease model and broaden it to an equity model. Not because you're engaging in subterfuge, but because that's actually the best way to actually get underneath the chronic disease epidemic.
I think we'll take one more question, then we're going to have to wrap up. Go ahead, yeah.
Okay, just building on your answer to that question and going back to what you mentioned at the very beginning of your presentation about narrative drives policy. I think that's incredibly profound, and I think we don't pay enough attention to it. There's a really interesting book I recommend to everybody by a literary critic of all people, Priscilla Wald, called Contagious, about how we've become trapped in certain narratives, disease narratives, and they constrain our policy responses. My question is, how do we substitute better narratives, more social community level narratives? I think you provided kind of the skeleton or the blueprint for some narratives, but I think we need actual real stories with real people involved. Yeah. Unnatural causes presented sort of snippets of possible narratives. I'm challenging my students to investigate better narratives, but I think that may help answer the previous question because narratives do drive policy and funding.
I will answer that by saying yes. This is, I think, the most challenging work in public health right now is to figure out how to shift narratives. And you know, we're tinkering. We've made some success in California. I mean, we changed the narrative around undocumented people. We got the Associated Press, the LA Times to stop using the word illegal alien. When you're talking about illegal aliens, you're not thinking about what policies can I do to improve the well-being of illegal aliens. So they no longer use those terms. We think that's a major narrative shift because, you know, that term is fraught with all kinds of blames and othering. An undocumented, you know, person is somebody who's, you know, may have a claim to be a U.S. Citizen or resident. And we're able to drive policy around undocumented people much more easily than we can drive policy around illegal aliens. Similarly, we've been working on this issue of sexually exploited minors and this notion of child prostitute. We got the LA Times and San Francisco Chronicle to stop talking about child prostitution. They now talk about exploited youth. And that drives a whole set of different policies when you're talking about exploited youth. So there's a little things. The key to narrative change, and there are a lot of smart people in public health schools that are working on narrative change. I think more investment needs to happen in that realm. But the key for us is about both the stories and the storytellers. The stories have to be broader. They have to tell a landscape rather than a portrait story. They have to talk about sort of what people have to navigate in order to pursue health. But then they also have to allow people to tell their own stories. You have to humanize people. In our sort of public consciousness, you've got this dehumanization that's happening around young African American boys, formerly incarcerated people, LGBTQ, immigrants. And Donald Trump is the poster child for that. He literally stood there and said, they're rapists and they're murder. And people are like, yeah, that's what they are. I mean, that is an intentional, whether he's smart enough to realize he's doing it or not, intentional effort to dehumanize that population and therefore to change policy around how that population can actually navigate society. So that the narrative switch, and we have a history, I didn't mean to say that it's all Abraham Lincoln, racism. We have a history, a counter-narrative in this country that, at times has risen to the surface. Around after World War II, briefly after 9/11, this narrative of sort of community and shared, burden and equity. And that narrative from time to time sort of rises, and then events change, and then you got the Trump narrative sort of dominating. It's really critical to recognize that you can change a narrative. You can invest in a new narrative and watch that narrative take hold.
Well, thank you. This has been wonderful, very inspiring.